Hello friends, this is Sudharshan, and in this episode we will talk about the chapter Neuro-ophthalmology, some important concepts here. First we will see about optic neuritis, which is the inflammation and infection of the optic nerve. So as such the cause is unknown, so mostly these are causes which I will be listing. Mitochondrial DNA diseases like Rett syndrome for example, demyelinating disorders, it is said that this is the most common contributing factor like multiple sclerosis and Guillain-Barré syndrome. Then certain infections like bacteria, we have the granulomatous conditions. Viruses, we have exanthems and whooping cough, and fungi cryptococcus. Also autoimmune disorders, SLE and sarcoidosis, and drugs like ethambutol. So two types are there based on ophthalmoscopy. So anatomically three types. We have papillitis, neuroretinitis and retrobulbar neuritis. So it will be based on three structures: retina, optic disc and the nerve. So if the retina and the optic nerve is affected, neuroretinitis. If the optic disc only affected, so papillitis plus neuroretinitis is equal to retrobulbar neuritis. And another is typical versus atypical. So mostly, as I told, demyelinating disorders said to be the most common cause. Diabetes is one more disease you can add, and there may be other causes like I've listed out. So clinical features in this case, we have the symptoms. So because of damage to the retina, optic disc and the nerve, the vision will be compromised. So sudden and progressive vision loss will be there. Then dark adaptation and color vision will be reduced. Then there will be retinal pain and dull headache. But two most important symptoms to take care of is Uthoff symptom, which is the episodic transient visual obscurations. So there will be regular episodes of vision loss. And Pulfrich phenomenon, where the depth perception will be impaired. Almost the same, like we can have same decreased color vision and visual acuity. Then Marcus gun pupil, because the optic nerve and the visual pathway and the pupil reflex is involved. That is why color vision, visual acuity decreases, visual evoked response reduces. Photomas will be seen, Marcus gun pupil will be seen, which we also call it as relative afferent pupillary defect, positive on swinging flashlight test. And FFA, fundus fluorescein angiogram and OCT. Optic coherence tomography will show decreased retinal circulation, and electroretinogram there will be decreased B wave, electrooculogram will be subnormal, and the diagnosis would be the same for the optic atrophy, optic neuritis and papilledema. That is an urgent CT MRI of the orbit or brain. So treatment would be of the underlying cause. Mostly it's idiopathic, so we need not do any treatment. Observation can be done. So mostly we can give steroids like methylprednisolone or interferons to reduce the inflammation. Next is optic atrophy. So when it comes to the classification of optic atrophy, so three are there: primary versus secondary. Again, primary we don't know the cause. Mostly syphilitic tabes dorsalis is said to be the most common cause, along with demyelinating disorders. Secondary, there are other causes which I have listed: optic neuritis. And ophthalmoscopic classification. So in this we can have five types: primary, consecutive, post-neuritic, ischemic and glaucomatous. So when it comes to the color, all of them will be chalky white except the consecutive type, where yellow waxy pallor will be seen. The optic disc and the retinal vessels, the changes can be very well appreciated in consecutive, post-neuritic and ischemic types, and it is very faint when it comes to the primary and the glaucomatous type. Right, so these are the various differences. And in ascending and descending, the difference will be at the medial geniculate body level. So if it is up to the medial geniculate body, it's ascending. that is descending. Yeah, and when it comes to the symptoms, there will be vision loss and Marcus gun pupil will be seen. So diagnosis will be to do an urgent CT MRI of the brain, and treatment will be of the underlying cause. And next is edema. So what are the probable causes of papilledema? Most common causes when the intracranial pressure is elevated. We'll come to the pathogenesis next. So it is mostly because of any inflammatory conditions like papillitis and neuroretinitis. Then apart from that, ocular any vascular conditions like CRVO or anterior ischemic optic neuropathy, then orbital conditions like Graves' disease or retinoblastoma, and infiltrative conditions like leukemia or lymphoma. So coming on to the pathogen, as I said, the ICP raise is the most important factor, because of which there is subdural space pressure that raises in the retrolaminar portion of optic nerve. Then there is a stasis of axoplasm in the prelaminar region of the optic disc. Then there is a disc edema along with venous congestion and stasis. So when it comes to the disc edema, there will be optic disc cupping, elevation, atrophy, asymmetry, blurring, hyperemia, hemorrhage. So many changes. And there will be patens lines or retinochoroidal tear will be seen. And in the venous congestion and stasis, the retinopathy changes. Cotton wool spots, flare hemorrhages, hard and soft exudates, etc. And when it comes to clinical features, very general symptoms. ICP symptoms like headache, nausea, vomiting, diplopia. Most commonly 6th nerve palsy will be seen, and headache will be worse in the morning. That's the important thing here. And when it comes to the ocular symptoms, we have 4 stages here: early, fully developed, chronic, and atrophic. So anytime the early stage, mostly it is asymptomatic, very mild disc blurring will be seen here. And as we go from the fully developed to atrophic, the visual obscuration will increase, the visual acuity and color vision along with pupillary reaction will be impaired. And yes, as I said, in the early stage, mild disc blurring with hemorrhages will be there. In fully developed, the optic disc changes and the venous congestion. Those changes which I have described, that will come. And chronic is the resolving stage, where most importantly champagne cork appearance will be there. It looks like an inverted wine bottle. So whatever the retinopathy changes are there, that will resolve. And totally there will be whitish sheathing in the retinal vessels in the atrophic stage. So diagnosis can be done using urgent CT MRI of the orbit or brain, and treatment will be to address the underlying cause. And last but not the least, amblyopia. So amblyopia is a partial or reversible vision loss in one or both the eyes. So in amblyopia, mostly there is absence of any disease. So there are various reasons why it can occur. Squint is the most common. Apart from that, cataract, corneal opacity, glaucoma, ptosis. Then apart from that, any refractive errors may be the reason for amblyopia as well. So treatment will be to address the underlying cause. Suppose it's a cataract, we do a cataract surgery. Suppose it's a corneal opacity, we give medical treatment with 5% sodium chloride or anhydrous glycerin. If it's a ptosis, we will surgically operate for it. Any refractive errors, we will do corneal refractive surgeries and prescribe the required glasses or lenses. And if it's a squint, so we will do the computerized pre-operative and post-operative exercises and occlusion therapy to increase the strength of the extraocular movements. So that is all about neuro-ophthalmology. Thank you so much. We will see in the next lesson.